Well friends, in today's video I will be talking about the minimally invasive percutaneous osteosynthesis, that is MIPO plating for proximal tibia fractures. I will be covering some basic tips which will be helpful whenever you are encountering similar cases. So whenever the fracture is in proximal part of the tibial metaphysis where the nailing may be difficult, you can definitely go for MIPO plating. Or in cases in which this part is terminated in the metaphyseal diaphyseal region, then also you can use the MIPO plating as a bridge plate. And in those cases where the fracture is articular one but is a simple, that means you can reduce the articular fragments by indirect methods like clamps and K-wires, then also you can use the MIPO plating technique for fixation of these fractures with variable combination in the metaphyseal diaphyseal region. Because the plate used for fixation of these fractures is of 4.5 mm profile, it does provide good stability for the stability of the medial segment as well. But whenever there is articular combination, then definitely you have to go for another plate that is to be placed on the medial side as well. In those scenarios, you can definitely go for 3.5 mm plate on both sides. But in cases when there is no articular combination, you can definitely go with single 4.5 mm locking plate on the lateral side. So this is a case in which you see there is articular extension of the fracture line here, and there is some metaphyseal combination as well. This is the AP view and this is the lateral view. But the articular fracture appears to be a simple one. That means you can simply compress this fracture using a clamp and temporarily secure the fracture with K-wires. Therefore, it is a good case for MIPO plating. The nailing could also have been used, but you see the fracture line in the CT is quite close to the entry point of the nail. Whenever we are going to make entry for the nail here, we have tendency to displace this fracture, or that can result in widening of the tibial plateau. So, a MIPO plating is a better alternative in such scenarios. And also in those cases, whenever you are not comfortable with the nailing in the proximal tibia fractures, like here you see the proximal segment is quite small and there is a faint fracture line which is extending here. So if you are not comfortable with the nailing in these cases, then also the MIPO plating is a good option because it does not damage any soft tissue. It just makes an entry point, and the screws in the distal segment are placed in percutaneous manner, that means minimally invasive manner. So whenever you are positioning the patient, you can either use a simple table and put a sandbag underneath the gluteal region. That will help in neutral rotation of the limb, because normally the limb tends to go in external rotation. But if you are short of assistance, then definitely you can use the fracture table also. With the help of fracture table, we will be reducing our assistance because the alignment and the reduction will be easy by just putting the traction, because with the traction we will be able to gain length. Once the length is gained, then definitely the alignment reduction becomes more easier. Only problem with the fracture table is that there is tendency of extension at the fracture site. But if you are having at least one assistant, he or she can just put support just beneath the fracture level to prevent the extension. While doing that, you can temporarily secure that particular alignment with multiple K-wires. We'll see in the coming images. So whenever you are using the fracture table, just ensure that the area for plating is free. That means suppose you have covered the limb till here, but your plate is going to end somewhere here, then definitely you are going to face difficulty. So you have to ensure that the length which is required for the plating is freely exposed whenever the draping is done. Like here, if the fracture is in this zone, we want this part to be exposed. So this part is appropriately exposed. So first thing in every tibial plateau fracture is to secure the articular block first. So here, if the fracture is a simple one, then definitely after placement of the clamp, you can place temporary K-wires, multiple K-wires in the articular block that will prevent the displacement at the articular site. So this kind of assembly is what we need whenever we start our MIPO technique in articular fractures. The second thing is to secure the appropriate alignment of this articular block with the metaphysis. So if your fracture line is kind of oblique like this, then definitely you can use this clamp, the Weber clamp, that can help in near approximate alignment of the metaphysis to the diaphysis. But in case of combination, the fracture table alone will be helpful in gaining good alignment, and the rest of the things will be done with the help of plate that we will see in the coming slide. So once you have aligned the metaphysis with the diaphysis, then if possible, use few K-wires to secure this alignment between the metaphysis and the diaphysis like this. So this kind of assembly we have to achieve if possible. If it's not possible, then also there's no issue at all, as there are a lot of, as we will see in the coming slides, that will help in gaining good alignment. So here the reduction was earlier like this, but after using this Weber clamp, we have reduced it to near appropriate alignment. And while doing all these steps, always ensure that the lateral view is also appropriately aligned. Minor translation is definitely acceptable because this area is non-articular, but overall alignment should be satisfactory. So here we see these K-wires are securing the articular block, and these two K-wires are securing the metaphysis with the diaphysis. Now the skin incision. So you have to mark the major bony landmarks around the proximal tibia. You have to mark the patella, you have to mark the tibial tuberosity, you have to mark the proximal part of the fibula, and you have to mark the Gerdy's tubercle. So your incision is slightly curved, or you can say inverted J-shaped, and the upper extension of this incision goes till the level of joint line, while the lower goes in the mid-lateral area, and it is centered over the Gerdy's tubercle. The Gerdy's tubercle is important landmark because whatever implant you are using, it has to be behind this bony landmark. If your plate is coming anterior to this, then definitely you are going to face problem in closer, and also it is going to impinge whenever the patient does the movements, because it marks the insertion of the iliotibial band, and you need not to put any implant over this insertion site. It has to be behind this area. So once you have made the skin incision, you do the subcutaneous dissection, and while doing that, you will be able to see this bony prominence, which is quite visible here also. So this bony prominence is the Gerdy's tubercle. So your deep incision has to be bone deep, and you have to lift the soft tissue layer deep till the bone behind the Gerdy's tubercle. Our deep incision is going to be like this only, similar to our skin incision, and you have to go bone deep. You need not to expose anterior to the Gerdy's tubercle, because there we have the important capsular attachments of the joint and also some part of the extensor mechanism, and it is not required to go anterior to this point. You have to remain posterior to this point, because this will be the area where you will place your plate. This posterior part is marking the origin of the anterior compartment muscles of the leg, and you have to lift them directly off the bone. There is no need to make layers in this zone, and once you are placing the implant, this whole layer of soft tissue will cover your plate. And if you are not able to cover this plate, that means something wrong has been done. Either your plate is coming anteriorly, or you have not lifted the layer deep till the bone. So always ensure that once you have done the subcutaneous dissection, you have to lift this muscular area through a deep layer which is deep till the bone. And once you have made the incision, always confirm the appropriate plate length by putting the plate over the fracture site. Then you will be able to know how many screws are going to be there distal to the fracture site, because the proximal screws will remain constant. There are 4 or 5 screws which are going to be there in the proximal segment, and these shaft screws will be variable according to the plate size. So you have to secure at least 3 locking screws distal to the fracture site, and there should not be any locking screw. You can say around 1 to 2 centimeter from the fracture site, there should not be any locking screw. While cortical screw can definitely be used close to the fracture site, you need not to tighten it. If it is not tightened, it will not make your construct rigid. You can just use the cortical screw for the positioning of the plate, because sometimes the plate remains off, and by tightening the cortical screw, you are able to give the fracture the shape of the plate. But you need not to tighten it maximally, because that can actually make your construct rigid if it is close to the fracture site. I will be showing you that step in the subsequent slide. Now, as far as the plate length is concerned, you can either do that intraoperatively by just putting the plate over the limb and check under the C-arm whether you are getting sufficient number of screws in the distal segment while positioning the plate proximally in a well manner. And you will have to ensure that the screw density in the distal segment should be 50%. Now, once you have made the skin incision and you have lifted the muscular mass from the bone, then you will be able to expose this lateral surface of the proximal tibia, and you have to ensure that no K-wire is hindering your exposure of the lateral surface. That means if the wires are coming out of this area, you have to bury them inside so that they remain inside the articular block, or you can say the metaphysis, but they are not protruding in this area, because you have to pass the plate from this area. The wires, if present, will block the passage of the plate. So you can use this instrument, the Cox elevator, which is long enough to clear the soft tissue from the lateral surface of the tibia and will make a track for passage of the plate. But if you are not using it, you can use the plate also as the soft tissue elevator. You see the plate has terminal end which is tapered. So this tapered end can be slid over the lateral surface, and while doing that, you have to simultaneously feel for the lateral surface bone. So if you are facing that some resistance is there, then that means you are over the lateral surface of the tibia. But if there is slight loss of resistance when you are passing the plate, then definitely your plate is either going anteriorly or posteriorly. You can use the lateral view of the C-arm to confirm whether the plate position is appropriate or not. Here in this video, you can see we are using plate directly over the lateral surface and sliding over it using the tactile feedback. You see here, the plate has been slid over the lateral surface, and while doing that, you have to ensure that this proximal part of the plate remains in an appropriate area. So you have to adjust this position using a locking sleeve in this zone. This locking sleeve should be in the topmost hole of the plate. By pulling that proximally, you can secure the plate in a better alignment, so this flare of the plate should match with the flare of the proximal tibia. What you can do, you can make this topmost part of the plate close to the joint line. That means this topmost part of the plate should lie close to the joint line. That means somewhere here, but it should not protrude above the joint line. You can definitely keep it slightly lower than the joint line, but not above the joint line, because if it remains above the joint line, then it is going to hinder the capsular motion, and patient will always complain of pain because constant impingement of this prominent end of the plate over the capsule. It has to be at a slightly lower level to the joint line. And after doing the position in the AP view, you have to check the lateral view also. In lateral view, your plate should not be lying anterior to the tuberosity. This proximal part of the plate often comes anterior to the tuberosity, and you have to avoid that, because what will happen if it remains anterior to the tuberosity? It is going to stretch the skin anteriorly, and you will face difficulty in closure of your lateral wound. And often, because of constant stretching of the skin, it results in necrosis also, leading to wound healing complications. So this part should not be proud in the lateral view. You have to ensure that this part remains posterior to the anterior-most extent of the proximal tibia. So this is incorrect. We have to modify it. So this prominent part of the plate is often malpositioned when we are placing the MIPO plate. So this part has to lie under the soft tissue cover. So this position has to be modified to this. That means you should have sufficient bone anterior to this angulation of the plate. So you have to push the plate slightly posteriorly. So this position appears to be satisfactory. And once you have done that, you have to place a K-wire inside one of the holes in the proximal part. So here we are placing the K-wire in this hole, and always ensure that only one K-wire has to be put. I'll tell you why in the coming slide. So here we have placed a K-wire in the proximal part. Now suppose you have placed a K-wire in this hole and your plate is slightly off in the distal part. Then what you can do, you can slightly lift the plate anteriorly, and this K-wire will act like an axis. But if you have placed multiple K-wires in the proximal part before checking the distal segment, then definitely you are going to face difficulty, because the other K-wire will hinder the motion of the plate in the distal segment. So always keep only one K-wire, because that will act like an axis for the plate, and you will be able to manipulate the plate in the distal segment. So you will be able to get a motion like this if you have placed only one K-wire. And once you have secured the position in the distal segment, you can either place a K-wire in this hole to maintain that particular alignment, or you can place a K-wire slightly posterior to the plate, and that will prevent the posterior migration of the plate. So that's up to you. You can use whatever technique you are comfortable with. So here you see in the lateral view, the plate was posterior. So a simple maneuver, that means you have placed a step incision in the mid part of the distal segment, and from that steps incision you have placed an artery forceps, and you have placed the apex of the artery forceps posterior to the plate like this, and you are able to toggle the plate anteriorly to a better position. So you see, we have now centralized the plate in the distal segment. So this position now appears to be appropriate. While in the left side, you see it was more posterior, but now it is anterior. This part is fibula, this is tibia anterior cortex, and this is the tibia posterior cortex. So the position appears to be satisfactory now. After getting this position, we have to place a locking sleeve in the distal segment. And through the locking sleeve, we can either place a thick K-wire around 2.5 mm, or you can place a drill bit through the locking sleeve, because that will secure the alignment of the plate in the distal segment. Do not put any screw at this stage. Just put a K-wire or a drill bit inside the distal hole. Like you see here, we have placed the locking sleeve here, while ensuring that the plate remains central in the lateral view. And also, once you have placed a locking sleeve, if you face slight displacement of the plate anteriorly or posteriorly, then you can use the locking sleeve as a handle. You will be able to toggle the plate anteriorly or posteriorly with the help of the locking sleeve. And the moment you get a good alignment, that means the plate remains central, then pass the K-wire or drill bit through the locking sleeve. So the plate looks like this. In this terminal part, you can place either K-wire, but it is going to be difficult, but better to put a locking sleeve in this hole or in this hole. Place a thick K-wire or drill bit through that particular hole. I prefer placing the drill bit in unicortical mode. If we place the locking drill bit in bicortical mode, that means both the cortices have been entered. That drill bit is actually going through the locking sleeve. And if it is positioned while the plate was not perfectly flushed with the lateral cortex, then that is going to hamper the position of the plate in later steps also. So I prefer either using the K-wire or a drill bit which is unicortical. That means it is going inside the canal but not through the second cortex. So here we have positioned the plate appropriately in both AP and lateral views, but there are still some minor issues. You see, this cortex is still translating. That means distal cortex has to be aligned slightly more laterally. It is more medial compared to this cortex. If you want to manipulate this segment, you have to place a cortical screw close to the fracture site. So we are marking the cortical screw in this particular step which is close to the fracture site. So you see here the fracture is still here. So we have to avoid the cortical screw in this zone. This cortical screw which is nearest is somewhere here. So here we can place a cortical screw that will help in reduction of this translation. In this step we are drilling the hole for the cortical screw, but before engaging the far cortex you have to remove these K-wires, or you can slightly withdraw them. So here you see we have removed those K-wires, and when we are tightening this cortical screw we are able to secure the alignment. You see here, you see it is getting more aligned now. Now it is almost parallel to the proximal cortex. So at this step we have to stop. We don't want any over tightening of this screw, because one way it is going to hamper this alignment which we have now achieved, which appears to be appropriate. And also if we tighten it further it will result in the stiffness of the construct. That means the callus formation may get delayed if there is hindrance in the micromotion in this zone. So tightening of this cortical screw further is not required. Then once you are satisfied with the alignment, then definitely you can pass the locking screws in the distal segment by using multiple stab incisions like we have placed here. And through those stab incisions we can pass the drill sleeve, and through drill sleeve we can pass the drill bit and make hole for the locking screws. So we have to ensure that the screw density remains to be 50%, and the screw tip should only be slightly proud. It should not be proud to an extent that makes it palpable on the opposite side. Only the tip should be coming out of the far cortex. And this screw was prominent one. So once you have placed the locking screws in the distal segment and in the proximal segment, then you can change this screw to a shorter screw, or you can also remove it. So here you see the alignment appears to be satisfactory both in AP as well as lateral views. And one more thing, whenever you have placed the plate appropriately and you want to mark the locking holes in the distal segment, you can use another plate. Put that plate at a level with the proximal part matching with the proximal part of the already inserted plate, and then you will be able to locate these sides for the locking screws, lying here, and lying here. This hole was actually for the stab that we had used for placement of artery forceps to toggle the plate, but we have used this same stab for placement of the locking sleeve also. That's why it is appearing slightly posteriorly. So by using this plate as a template, we can mark the locking holes for the distal screws. You see here the plate is quite clear of the anterior prominent part of the bone. That means you have a thick soft tissue envelope that you will be able to use for covering the plate. If the implant is perfectly covered, that automatically reduces the chances of impingement and also prominence of the implant over the skin. So here you see the thick soft tissue cover is going to cover the implant, because this plate is not protruding anteriorly, and we get a coverage like this if our implant is not prominent. And the final picture is like this. This is the entry area for the plate, and these are the percutaneous stab incisions which were used for placement of locking screws and the cortical screw. And I told you that the plate should not be proud in the anterior part, because if this part remains proud, that is going to put pressure over the skin and you will face difficulty in the closure. Like here you see this part is quite anterior and this part is going to hinder the closure. Now you see here the surgeon had to struggle to close this wound, and there was a wound descent in the post-operative period, because you see this constant stretching over this area, because this prominent part is because of the apex of the plate. So it's better to avoid a complication like this. And when you handle the soft tissues in a well manner, the wound heals appropriately. Like you see here, if there's comminution in the articular area, then definitely you have to supplement your fixation with a medial plate. So till now I've told you about the technique for MIPO plating from the lateral side, and lateral side 4.5 mm plate is sufficient for the simple articular fractures or those which are extra articular in nature with variable amount of metaphyseal combination. So in those, the lateral side hockey plate can be used. But if the patient is an osteoporotic one and or there is articular combination, then definitely you have to supplement your fixation with a medial plate. And the medial plate can also be slid in a MIPO mode. What you need to do, you have to mark a skin incision on the medial side, but you need not to curve it like a J shape. You can simply give a longitudinal incision, and the incision should be sufficient to make entry of the medial side plate. Usually the T-shaped plate is there like this, which can be slid on the medial side. Often the residents are concerned whether to dissect the pes and serenus tendons or not, but that is not needed. Why? So this is a different case in which you see the plate has been placed over the superficial MCL, and these are the pes tendons. So the pes tendons are actually inserting over this area that is almost at the junction of the anterior third and the posterior two-third of the proximal tibia. So the amount of motion of the tendons in this area is almost nil. So placing a plate over this insertion will not hinder the motion of the tendons. So what you need to do, you have to make incision like this a small longitudinal incision which is sufficient for passage of the plate, and then you have to pass the plate subcutaneously over the pes tendons and the superficial MCL. You need not to expose the bone in this area at all. Just slide the plate over this area so that the plate ends somewhere here with appropriate screw density and bridging of the fracture site. Like you see here, the fracture has been bridged with the medial plate. There are no screws in this area, which should help in good callus formation. The terminal screws can be placed with similar technique as we have placed the screws on the lateral side. So the principles will remain same. Only thing you need to take care is to give a longitudinal incision here and pass the plate over the superficial MCL and the terminal part of the pes. You need not to expose the pes tendons, because otherwise it is going to be an invasive technique which is not required. So I hope this presentation on MIPO technique for proximal tibia fractures will be helpful for you in your practice. If you have any queries, you can definitely put those in comments. Thank you.